Weighted event of the day, we invite upon Padma Shri Dr. Rajendra Badwe.
Thank you very much. I am greatly honored to be the recipient of the first Professor M. Krishnan Nair Memorial Oration. Dr. M. V. Pillai, Dr. V. P. Joy, the eminent pioneers in cancer care in Kerala, Dr. Chandra Mohan, Dr. Thomas Matthew, and Dr. Bobbin Thomas. It is indeed a pleasure to be here, and it is customary that one declares some conflict of interest before one speaks about what one is going to say. And I have one or two conflict of interest that I need to declare. One is that I am an eternal optimist, so you might find a lot of positive things in my talk. The second bit is that I am extremely fond of numbers, so there will be a lot of numbers that will be showered at you. And the third component, which was earlier mentioned, that I am a skeptic. I do look at everything with skepticism, unless I'm convinced that there is data to support. And I remember the words of a gentleman from Czechoslovakia who was a professor of internal medicine in Dublin. The name is, I'm bad at remembering names. But the gentleman, it will come to me. The doctor mentioned that skepticemia is a disease of very low infectivity, and successful completion of medical education confers permanent immunity against skepticemia. So I have kind of escaped that permanent immunity to retain my skepticemia. A lot has been spoken about Dr. Krishnan Nair, and I just had two very fond memories. One is that I always looked upon him as an eminent leader of teams. He would get people around him very, very easily. And that's not easy to understand, easy to achieve. A lot of us tend to say that I am there and I am the best. I don't need anybody else. Whereas here was a man who would get everybody around and to get to the work that he was doing, and would also be inclusive so that others' work was also part of his thought process. And the second, very dear to my heart too, I have shared that little glass of amber with him at least about 2-3 times, and his love for the single malts, even I shared that. So those are the two fond memories about Dr. Krishnan Nair. What I intend to take you through, a bit of it I have earlier spoken, but I will go into the details of the research that was earlier mentioned by Dr. Pillai. And when I say surgical strike, it would essentially mean the precision. When I say surgical, it is the precision strike. A surgeon, as he cuts, he tends to save all the vital structures, but gets the tumor out. So it is this precision strike which I name surgical. And since I am a surgeon, I have included this as my topic. And we cannot deal with any enemy unless we gauge the enemy. So let's look at what do we have. These are some numbers. US, UK, no more 300, they are at 350 per 1 lakh population per year. That's the number that gets afflicted by cancer in UK and in US. Urban India, this number is 100. Semi-urban India, 60 to 75. Rural India, 40 to 50. We are not missing in rural India. We are not missing cancer. It is low in rural India. And we run about 3 rural cancer registries wherein we do a house-to-house survey somewhere close to about 1 million population. And we know that there is no cancer there. It is 40 to 50 consistently in all the rural pockets. Indonesia, just an example in the neighborhood, more on the oriental side, since I didn't allude to any numbers on the oriental side. But what is unique about India is that for last 20 years, these numbers of urban 100, semi-urban 60 to 75 and rural 40 to 50 have remained same. They have not changed. Unlike the BRIC countries where these numbers have changed in these locales. So there is something good about it, but what is not good, or what is likely to affect us more, is that there is 5 to 10% urbanization that's happening every decade. And this number of 5% going to 10%, going to more than that, is rising with the years of decades that have passed by. So obviously, by the time we reach the whole India being urbanized, all that 70% of 1.4 billion is going to have 100 as its number. And presently that number is 40. So that kind of big numbers we are likely to see in years to come. And why are we so different? So there is something to smile about, that we have not increased, and something to say, why are we different and can we change? Look at the numbers. Prostate 50 in US, 9 in India. Lung 60 in US, 10 in India. Colon 55 in US, 6 in India. Oral cancer 4 in US, 23 in India. Breast 100 in USA, it is 120 now. 30 in India, urban, 9 in rural India. Cervical cancer, 7 in US, 24 in general Indian numbers. But if you look at Mumbai Cancer Registry, it is 7.5. The last number that we got 2 years ago was 6 per 100,000. So we are reducing as far as cervical cancer at a breakneck speed. 6 as defined by WHO is rare disease if the incidence goes below 6. So we need to be cautious that there are something good things, something not so good. Obviously, suffice to say that prostate, lung, colon, these 3 cancers are the ones that are screened very greatly in those countries. We are not screening it, fortunately. And our diet is fantastic. So let's continue with the same diet and just not say everything from West is best and adopt that at the moment. I will not go into the controversial things, but suffice to say that our mortality is 64.5 per 100,000 and the US mortality is 105 per 8. We have something to smile about, but we can't be complacent because we have something to smile about. Because our numbers are big because of our population. So look at what are the numbers. 40% of our cancer is due to tobacco. 15% of cancer is due to obesity, and this is the cancer that is rising. And 15% of our cancer is infections, which is rapidly reducing. Cervical cancer is reducing, stomach cancer is reducing, penile cancer is reducing. Each of these cancers are reducing at breakneck speed. And the commonest cancers here are oral cancer, breast cancer, and cervical cancer. All 3 cancers have 2 unique qualities. They lend themselves to early detection and they are preventable. Imagine both those things, that they're preventable and they lend themselves to early detection very easily. I will not go into the details of tobacco prevention, but just to quickly reduce. If tobacco is reduced, it will be nice if the regulators like Dr. Joy were to look at, let's keep a 10-year mark. We are in 2022. By 2032, if the production of tobacco was to be stopped, let's have some nice cash crop for our farmer friends, and we could then reduce cancer, reduce hypertension, reduce heart attacks, reduce stroke, reduce the burden on our healthcare, and reduce all-cause mortality. Prevention for tobacco is there. From there on, infection, just running water, potable good water, personal hygiene, good food preservation is what will give And these cancers are already on the wane in Kerala. Not just in Kerala, all urban and semi-urban India. Obesity is related to diet. I think we need dedicated cycling tracks in India. It's customary that we have lots of bridges that are being built. Let's build those bridges two-tier. The top can be for vehicle, the lower one can have travelators as we have on airport. Let that be the mass transport. Everybody walking. If city were to walk, when I talk of Mumbai, from Warsaw to Gateway of India is through the coastal road. The distance is 14 kilometers. Imagine 3 travelators moving one by the side of the other, first moving at 5 kilometers, the next at 10 and the third at 15 kilometers. If you start walking on the footpath, you're walking at 5 kilometers an hour. Step onto the first one. Start walking on it, you're walking at 10 kilometers. Easily step onto the next one. Walk on it 15 kilometers, step onto the last one. You will cover 14 kilometers from one end of Mumbai to the other end at a speed of 20 kilometers an hour. The best speed today in India or in city of Mumbai at any given time is about 8 kilometers per hour, sitting at one place, producing huge amount of pollution, and imagine the whole city walking like this. Just few thoughts. Screening, a very touchy area. It was mentioned that I was against mammography. So let's look at screening for common cancers. And what are the common cancers? The common cancers here are oral cancer, cervical cancer, and breast cancer. There is a fantastically good study from Kerala that showed oral cancer examination itself will improve and reduce mortality by 30%. Let's do that, adopt it for all those tobacco chewers and smokers to look for oral cancer and try and reduce that mortality. Breast cancer. The most common thing that we need to do is that it should be common thing. I mentioned 3 cancers. The second important thing that there should be robust evidence that the mortality related to disease reduces in a randomized setting. And the third component, that there should be least overdiagnosis. Why do I say overdiagnosis? Our system, and not just our system. Dr. Pillai mentioned the duration of waiting time before biopsy happens. Any system, all systems globally are stretched to its maximum. If we were to overdiagnose, we will add numbers to that. So in absence of overdiagnosis, if we were to save lives, that would be ideal, and I'll give you a few examples. And the places where there need not be screening is prostate, lung, and colorectal. Colorectal in our situation, because it's a rare cancer. It's not a very common cancer, our diet is excellent, but for prostate and lung, no screening has saved lives in randomized setting. There is only CT scan related trial comparing with chest X-ray that has shown some improvement, a very small improvement in reduction in deaths, but it is not. It's a fatal cancer and we need to do prevention rather than early detection for these 2 cancers. Let me take you through 2 quick studies. 150,000 women, 75,000 randomly allocated to having visual inspection followed by cytology in one arm and the other arm having awareness. 30% reduction in mortality, 75,000 women in one arm, 75,000 in the other arm. A 12-year follow-up showing reduction by 30% in deaths related to cervical cancer. Implemented today in 20 out of 29 states across India. The second part of the study was the same women also had physical examination performed by trained health workers. 75,000 women had that, 75,000 women had awareness. And 30%, 29% reduction in deaths related to breast cancer. Now let me put that in the context of mammography, and then you will understand why am I so against mammography being used as a screening tool. The first study that happened in United States looked at the HIP study, looked at physical examination plus mammography versus awareness. Both of them put together had a 30% reduction in deaths in women above 50. No difference in women below 50. At that time, it was not possible to know which one of them contributed to this 30%. Was it mammography or was it physical examination? While the next studies happened, the ideal study that was run at that time was by the Canadians. In effective population, women above 50, where both together were effective, they ran a study randomized of physical examination versus physical plus mammography. What was the importance of mammography or addition of mammography over and above physical examination? That study has had a 25-year follow-up, no difference in mortality. So mammography did not add anything to physical examination. What was unfortunate at that time, that there was no study that compared physical examination versus nothing. There wasn't. Ours was the first study that looked at physical examination versus nothing, 30% reduction in mortality. So then what's the flip side? We can still use mammography. The flip side is that at the end of 20 years, the incidence in control arm and the intervention arm came together in breast cancer physical examination trial, but in mammography versus not, there was a 28% excess number of cancers in the intervention arm even after 25 years. What does that mean? 28% of the women in the mammography arm had cancer diagnosed by mammography, and in the other group, these cancers remained silent for 25 years. That means it was not supposed to be diagnosed. If it is not supposed to be diagnosed, that's where I call overdiagnosis. I will come down to that a bit later when I talk of what are we, all of us as doctors. We are not selling anything, we are taking care of our patients. But if we were to define ourselves as businessmen, what are we selling? The doctors are selling immortality. We don't want our patients to die. So what are we selling technically? Immortality. Imagine these mammography versus not. 28% of these mammographically detected cancers would never manifest. So I do physical examination and I do mammography, and I say that I will treat only mammographically detected cancers. What would that mean? Nobody will die. I do that for 10 years, and everybody in that city will say, if you get breast cancer, go to this man. You will never die. But in reality, these women should be comparing themselves with individuals who have never been stamped as cancer patients. They would have never surfaced. But they're comparing themselves with those who are dying of breast cancer. Quite unfortunate. If medicine is business, it is also a business wherein we don't create disease in society. We look at reducing disease in society, unlike any other business. From there on, I come on to what Obama mentioned: access, affordability, and good quality care. If we were to do that across India, we planned what was mentioned earlier by Dr. Pillai, the National Cancer Grid. As I talk, about 280 centers across India have come under this umbrella for uniform care. So if I seek a second opinion sitting in Kerala from Tata Hospital, the opinion will be exactly same as what is given in RCC Trivandrum. I have that much of relief that I don't need to leave my home and go far away for treatment. It's the same, and that is of global standards. So that's where we are at the moment as far as National Cancer Grid is concerned. We systematically set up cancer centers with hub and spoke model with the present government. There are many centers. We are running 9 centers across India, and there are, in the last interaction with the Prime Minister, he just mentioned one thing: be ready to create 1 center every 2 years. All the best for my successor. Uniform care across is what was done by the National Cancer Grid. People sat together to decide we will follow these guidelines, and these are stratified for the kind of infrastructure that is available so that nobody feels inferior, that if I don't have this, I'm giving an inferior care, because the outcome is the same. So talking about hub and spoke model quickly, that it's a distributed model minimizing patient migration and comprehensive cancer centers with hubs, and each hub was thought of for 40 million population, and that would have approximately, when all of it becomes urbanized, 40,000 cases, 350 bedded facility at 60 million capex in dollars and 10 million recurring cost. But if I were to follow the Tata model, where 20% pay us a 100% markup, 20% pay us 20% markup, and 60% don't pay us, they are covered by the state insurance. With all that put together, for looking after 80,000 patients, our recurring expenditure is approximately 360 crores annually. Of that 360 crores, we are able to generate 320 crores. The government gives only 40 crores. The Department of Atomic Energy gives only 40 crores for looking after 80,000 patients. It's a win-win situation, and the aftermath of looking after the whole spectrum of society. We get middle class, we get the lower class, we also get some of the individuals who can pay extremely well, and our understanding of disease is across the social strata. A model wherein this is for poor patient and that place is for rich patient is not sustainable. It will give a lopsided view to the doctors who are trying to understand disease. And it is with this kind of thing, and for 10 million a spoke, I will not go into the details, but essentially that spoke will deliver closer to homes what is being prescribed even in hubs. So delivery of care is what I was talking about through a model wherein we maintain a QA/QC with excellent peer review and a paperless system wherein you are open to inquiry from anywhere as far as patients go or from doctors or any of the doctors are concerned. Quality in healthcare was the third component, and these three were defined somewhere in 2008 when we launched National Cancer Grid. That we will have access, we will have affordable care, and we will also have a good quality. All those are part of the same. And the last point I would like to harp on is the cultural sensitivity. We alluded to we being waylaid by the complementary sciences, by gurus and whatnot. They can complement, no doubt about it, but they need not replace, they need not substitute what is proven to be an effective care. And that requires good navigators who will take them through the journey. So we have created a bunch of individuals trained who, while talking to the doctor, are looked upon as a family member, and while talking to the family, they are looked upon as the team members of the doctor that are looking after the patient. It is these individuals who run through a master's program in Tata Hospital. By now we have created about 80 individuals like this. Every year we take 40 individuals so that these individuals bridge the large gorge that is created between patient and doctors. I will not go into the detail. Medicines here are cheap. We hope that they are not spurious. We need to improve on everyday basis. This is something that is close to my heart, the kind of research that we do. I'll allude to few, and I will give you some background as to how this thought process came in. It was in 1997 that we started a small office called Clinical Research Secretariat. Created an infrastructure that could support running clinical studies, observational studies, running audits, doing meta-analysis, and running randomized clinical trials. All kinds of help, statistical help, data collection help, data analysis help, all kinds of support was offered to clinicians. The clinicians were also kind of recruited into understanding what are the statistical views and what are the burning questions in the clinic. And that's how we started 4 trials, of which the first I will allude to, that oral cancer patient without clinically palpable nodes, do we need to address that node at all? And Dr. De Cruz presented this as a plenary talk in ASCO. The previous 2 studies that I mentioned of the screening also were plenary talks at ASCO. And when we presented the third one, the then president of ASCO did come and tell me that I don't think we have hospitals in US that have 3 or more presentations plenary in ASCO ever. So this trial published in New England Journal of Medicine that there is a 30% reduction in deaths related to prophylactic neck dissection for oral tongue cancer. In breast cancer, let me take you through, it was mentioned about timing of surgery. And the serendipitous, the thought about timing of surgery was so serendipitous. As a routine, after finishing the outpatient in breast unit at Guy's Hospital, I would walk for lunch. And the lunch place, the lunch room, walk through Gynac OPD. And the Gynac Obs OPD on the wall had this huge cartoon of ovulation, which depicted that during the first half of menstrual cycle, the estrogens went up. And then there was, the moment the estrogen reduced, there was a release of an ovum. And then the second half came in with estrogen, progesterones both. And it suddenly struck me that what is movement of cell from one organ to the other? That's metastases, isn't it? How do we define metastases? Something in breast cancer has reached lung. So if something from one organ going to the other organ is metastases, this is happening physiologically. And if this is happening physiologically, there was another thought to it, that why aren't dizygotic twins so very common? And why that question? Dizygotic twins need 2 ova. When they're dizygotic, they are dissimilar twins. First of all, twins are uncommon. And dizygotic twins are even more uncommon. So what does that mean? That would just mean one simple thing, that after the first cell is extruded, the first ovum is extruded, there has to be a switch that stops movement of cells. So with that thought in my mind, I spoke to our cytologist. The top cytologist at Guy's Hospital. I asked her that, can you distinguish, looking at a slide, that whether this is a pap smear taken during follicular phase or during luteal phase? And the lady said, I can tell you like this. In a moment, even without looking under a high power microscope. I said, how do you do that? She said that during the follicular phase cytology, there would be at least about 1 million cells under the slide. And during luteal phase, I need to search, where are the cells? There are no cells. That means this movement of cell is true for all kinds of cells, not for ovum alone. It is for everything. And the moment ovum is extruded, the lining of that cavity, wherein the ovum comes out, starts secreting within seconds progesterone. So it is with this that if progesterone can stop movement of cells instantaneously, this slide now takes you to the single injection of progesterone given 3 days prior to surgery. And that showed a 10% reduction in recurrence and deaths if the injection was given 1 to 4 days prior to surgery. Such a simple intervention. And I'll take you from there. Unfortunately, you will find that very few people practice this. Randomized trial published, because there is no industry to support this. The only person that stands to benefit out of this is patient. We need to start using something that only stands to support patients and not patients and shareholders. That paper did attract an editorial in that. And then I come to the local anesthetic. How did we think of this? Prior to this, we had looked at that if a single injection of progesterone can do it, what is it doing to micrometastases? Did the micrometastases stop coming out? That means there was a surgical dissemination happening. And I looked back as to who has looked at the events at the time of surgery? The first person who did experiments in mice was Fisher. Bernard Fisher, who spoke about micrometastasis predetermining the outcome of our treatments, was the first one to produce or run experiments in mice. He implanted a tumor, allowed it to grow, and once it grew to a certain size, he implanted another small tumor in mouse fat pad and called that as micrometastasis. That means this tumor has grown and a micrometastasis has evolved after some time. Then he removed the primary tumor and found that this grew. Not only this grew, but newer metastases also appeared after removal of primary. Why should he do that? If he himself propounds that micrometastases predate and they are not affected by surgery, why should he run this experiment? Unfortunately, there was no evidence of the same thing happening in humans because you can't run a trial of surgery versus no surgery. We ran this trial prior to this trial that I'm showing here of those who presented with metastatic breast cancer, surgery versus not. Because surgery was not a standard of care. And in that, we found that the local control was excellent, but distant spread was reverse. It was higher, statistically significantly higher in those who had surgery. So there was first human evidence that surgery, events at the time of surgery made a difference. I am a surgeon, but I'm looking at my own intervention with a bit of skepticism. Then why local anesthetic? So before we did that surgery, we found that surgery was actually facilitating growth of metastases. We ran another small study, which was presented at AACR in USA. And what did we do there? We tried to find out on the next generation sequencing platform, was the tumor changing? And how did we do that? Before I start surgery, that means tumor is well vascularized, good nutrition, blood supply excellent, I did a core biopsy. Then patient is under anesthesia. Then I started surgery. When 50% of the surface of the tumor was denuded of its blood supply, I did a second core biopsy from the surface which was not denuded, from the opposite surface. That's a second core biopsy of the same tumor. And then the tumor came in my hand. I did a third core biopsy. And all these three core biopsies were sent for expression profile, mRNA expression on the next generation sequencing. What was I anticipating? I was trying to look for whether the tumor is changing at all. And what was the anticipation? If I'm walking on the streets of Trivandrum, is there any reason during daytime that I should have my survival instincts up? There is absolutely no reason. So my expression should be very, very simple, docile. Suddenly I find that there are 5 goons in front of me and I'm threatened. All my survival instincts will be up. And God forbid nothing should happen. But if I'm overpowered by these 5 individuals, I'll stop reacting. I have described 3 situations exactly similar the way we do tumor biopsy. The first one, when everything was hunky-dory, blood supply was good, oxygenation good, nutrition good, first biopsy. Good amount of our tumor biology is understood on core biopsy. The second one, threatened tumor. And the last one, lost cause, anoxic tumor in my hand. All our understanding of cancer biology is based on the first and the third sample. We have never looked at the middle sample. Between the first and the third, about 30 genes were up in the last one. And all these 30 genes were steroid genesis and transition from aerobic metabolism to anaerobic metabolism. So genes related to that were up in the last one. But the middle one had 900 genes. How many? 900 genes that had gone up and down. And somewhere close to about 80% of these genes were pro-metastatic. Motility. The EMT, epithelial mesenchymal transition related genes. So, what is it that I would express when I am threatened? I will have fright, I will be scared. I will have fight. I want to fight those 5 people. Or if I find this is a lost cause, flight. I want to run away. It is exactly the same as I would think as a host, every cell was thinking. So everything related to motility had gone up. Everything related to invasion had gone up. And my first thought when we did this experiment was that I sometimes take 5 minutes for denuding 1/2 surface of the tumor. In 5 minutes, billion cells are told at the other end of the tumor that there is something to be threatened. How does this signal go? Imagine what are the ways in which we have been taught in physiology. Hormonal signal. That means something coming from pituitary going in. Too long, too far away, too much of time will be required. It could be not endocrine but maybe paracrine, something secreted. But even diffusion will take some time across a 3 centimeter, 4 centimeter tumor. Then what else? In some of the head and neck tumors we tried the same thing and we did biopsy in 2 minutes and again the same thing. So in 2 minutes, what is the way in which one cell is talking to the other cell? It has to be electrical. And that's where depolarization through voltage-gated channels that Dr. Pillai mentioned. Sodium ingress. If the channels open, there is sudden depolarization of a surface and that transmits across the cells in seconds. All cells are alerted. And what is it that balances or stops this ingress of sodium or paralyzes voltage-gated channels? And that's local anesthetic. So we ran a study in 1,600 patients injecting local anesthetic during surgery. Under anesthesia, 700 or 80 patients or 90 patients had the local anesthetic injected and another 790 patients did not have it. Everything else was exactly similar on both sides. They had same kind of systemic treatment, they had same kind of radiotherapy, either conservation or mastectomy. And that's the survival difference. Imagine a local anesthetic injection, 0.5% lidocaine. The vial that you get is 2%. Diluted once into double the amount, second time diluted again, and then injected. Why did I do that? The reason is 4 milligram per kilogram body weight is the toxic dose, maximum dose. Beyond that, it should not be injected. So if I were to take 4 milligram per kilogram, in a 60 kg patient, I can barely inject about 240 milligrams of the total amount. But imagine the toxic dose was thought of by giving an injection and leaving it in body. What I am doing is injecting and within 10 minutes it is removed after waiting for 5 to 7 minutes. So we were safe. But if I were to inject a 5 centimeter tumor, all surfaces, it would take 200 ml of injection. So injecting from one pole, like an umbrella opening, similarly from the other pole, and if the tumor is big, from 2 other poles, so that all surfaces. And how did I confirm that the injection was effective or adequate? That one should not be able to use diathermy. Surgeons in this audience would understand that if there is too much of water content in the tissue, your diathermy does not work. You had to use knife. If the diathermy works, injection was inadequate. And that's how it is, that there is 4 to 5% difference in overall survival as well as disease-free survival. I want you to look at this graph. The left one is disease-free survival, the other one is overall survival. I would get some clue from the medical oncologist. I talk of systemic therapy. I get disease-free survival difference much earlier, and then I wait for 2-3 years for overall survival difference. There are not many trials that have had overall and disease-free coming simultaneously. We are treating micrometastases there. Here we are preventing micrometastases. The difference in disease-free and overall survival appears almost simultaneously. And it is exactly the same. I'll take you back. Look at this graph. This is also disease-free and overall survival by giving perioperative progesterone. Both have appeared almost simultaneously, and both put together, we are reducing the recurrence rate by almost 2.5 times. 2.5 times recurrence is reduced. In these 1600 patients, each one was mentioned, each center was told that you predefine your protocol beforehand. And 1100 patients coming from 5 centers mentioned that they give progesterone also as pre-op. So both groups, control as well as intervention, received progesterone in 1100 patients, and in 400 patients they did not receive to either of them. But they were comparable. When I looked at a graph of that, again a 12% difference in disease-free and overall survival by giving. So an effectiveness of progesterone was also visible. Before I conclude, I have 2 things to mention. We need to address with good access if we have to have economic growth for healthcare. And healthcare delivery is not a business, but it needs to be run like one. So all QA, QC, what we need to do needs to be taken care of. But if I'm selling a mobile phone, I want everybody in my precinct to have my mobile. But if I'm selling immortality, I don't want everybody to get disease. In addition to immortality, I also work towards my irrelevance. I work towards reducing disease and not creating disease in society. This is what has happened in majority of the economies where medicine is business. We need some simple solutions. I showed you 2 simple solutions which can save lives. And when it comes to simple solution, I am reminded of a stanza, the first shloka from the 15th chapter of Gita, which my grandmother used to make me recite at bedtime. This chapter deals with action when there are uncertainties in front of you. And how are these uncertainties? It describes the way life is. And it goes this way. Urdhvamula adhashakham ashwatham prahuravyayam chandamsi yasya parnani yastam veda savedavid. What does it mean? That the tree of life with lots of uncertainties is like an inverted tree. The roots, which are the solutions, the causes for your uncertainty, are staring at you. They are very simple. But we are so used to digging in to find roots that we'll dig in. And if we dig in, what will we find? We'll find some beautiful leaves, beautiful flowers, very attractive, but they're not the solutions. Solutions are simple and staring at you, the form of inverted tree of life. Thank you very much.
Thank you very much, sir. We request you to kindly remain on stage. It is such a privilege to listen to you speak about cancer research like it's an interesting story. We also invite upon Mrs. Vinaya Boban, beloved of Dr. Boban Thomas, to hand over our gift to Dr. Rajendra Badwe.